Good afternoon, everyone. Welcome to the Hemophilia Federation of America's Blood Sisterhood Program webinar series. Thank you for joining us this afternoon. My name is Janet Chepka. I'm HFA's Program Director and Blood Sisterhood Program Manager. Before we get started, I'd like to just go over a few helpful webinar tips. This afternoon's webinar will last approximately 1 hour, and it is being recorded for future playback. We certainly welcome your participation and questions during the webinar. However, your audio will be muted during the entirety of the webinar, as this helps limit background noise that may disrupt the presentation. If you have a question, we encourage you to type it into the question box located at the bottom of your control panel. Questions will be passed along to the presenters to be addressed at the end of the webinar. HFA would like to take this time to thank CSL Behring as well as our CDC collaborative partners for their support of HFA's Blood Sisterhood program. They help make these educational webinars possible. Today's webinar presentation is titled, Making Strides Toward Improving Care for Women and Girls with Bleeding Disorders. In this educational webinar, attendees will learn about the Foundation for Women and Girls with Blood Disorders and get an overview and update regarding its Women and Girls Blood Disorders Clinics of Excellence Directory project. The webinar will also highlight one example of a Clinic of Excellence from the Young Women's Hematology Clinic at Nationwide Children's Hospital in Columbus, Ohio, and will describe how the providers at this clinic are working together to improve the care for young women with bleeding disorders. Today's presentation will begin with Anne-Marie Nazaro from the Foundation of Women and Girls with Blood Disorders. Anne-Marie Nazaro is the founding executive director of the Foundation of Women and Girls with Blood Disorders. Anne-Marie has more than 25 years of leadership experience in the nonprofit sector, including serving as executive director of a regional nonprofit focused on the health of women and senior citizens, and as Vice President for Education at the National Hemophilia Foundation, where she inaugurated and helped develop the first awareness campaign for FWGBD and bleeding disorders in women. Thank you for being with us today, Anne-Marie.
It's my pleasure, Janet. Thank you. And good afternoon to all of our women and others. I'm sure there might be some who aren't women in the audience. I'm really pleased with this partnership that we have with HFA and the opportunity that it gives FWGBD to speak with and to interact with the patient population, women who have bleeding disorders and other blood disorders themselves. I start with this, I think, rather well-known study that was done through the CDC. Kurtava was the lead author when it was published in '04, and it seems kind of a vintage piece, but I like to use it because it's iconic. It's rather a seminal article where back in the early 2000s, we came to the sure realization that diagnosis for women with bleeding disorders was delayed to the crisis proportion. If you see here the final note, average time from first symptom recognition until clinical diagnosis being 16 years, that is a public health crisis in our eyes. You can see also that the women who were interviewed, the 75 women with VWD, had their first symptom when on average at the age of 6. Now this is looking back, they probably, once they knew, they said, gee, I had terrible mouth bleeding, gum bleeding, dental bleeding from 6 years of age. And then heavy menstrual bleeding was my leading symptom, as reported by 84% of the 75 women, but then 16 years to a definitive diagnosis. This fact catalyzed the women you're going to see, I believe, in the next slide. These are, we like to say, our founding mothers: Andy James, OBGYN at Duke; Roshni Kulkarni, hematologist and former head of the CDC Division of Blood Disorders, and now at for a long time at Michigan State University; Barb Kunkel, who was at University of Pennsylvania and is now at University of Washington, Seattle. These women meeting at ISTH in '09, summer 2009 in Boston, decided that given the state of affairs and the long route to diagnosis, particularly for women with bleeding disorders and other issues and reproductive issues for all women with blood disorders, we needed a foundation focused on changing those data and making sure that all women and girls with blood disorders are correctly diagnosed and optimally treated and managed at every single life stage. From the 6 years of age when those women on average recognize the symptom, through periods, through pregnancies, and through menopause. Next slide, please. I'm not going to read these to you. They're the objectives that Janet so well articulated at the top of the webinar. So next slide. If we want to stem the long journey to getting a definitive diagnosis, we feel we need to look at what we know from adolescent girls, because we'd like to target them, not exclusively. We work with women at all ages and life stages, as we say in our mission and our vision. But importantly, we learn things from the adolescents. 40% of our adolescent girls are reporting heavy periods. We recall from the earlier slide, that's also the most common presenting symptom for all women with bleeding disorders. In a number of studies that were reviewed by Frischman et al., in the citation below, you see the author, the lead author, and the name of the article. He reviewed a number of articles and research projects and studies, and he saw that between 10 and 48% of adolescents with heavy menstrual bleeding had an underlying bleeding disorder. We are adamant about targeting in an important way the young women and adolescents. That's the way to stem the 16 years till diagnosis. That's an important way. Next slide, please. One of our board members, Jen Dietrich, did this study looking at 241 OBGYN residency programs across the United States. Look at the appalling data from this study. Interns, year one, getting 9 hours of training in the medical management of heavy menstrual bleeding. 11 hours in the second, third, and fourth years. 67% of these residency programs, the representatives of these programs reported that the training in heavy menstrual bleeding and bleeding disorders was sufficient. That's two-thirds, over two-thirds of them saying it's enough. We don't think it's enough training. Less than 25% of these programs said that their residents that would report or send for further tests for underlying bleeding disorder when they encountered these young women or adult women with heavy menstrual bleeding. And the residents inconsistently asked appropriate questions regarding bleeding history of the young women and adult women. When you look at this kind of gap in learning and gap in training, you understand how important it was for Roshni, Andy, and Barb to say we needed a foundation. And the initial phase of our foundation, we're starting out for several years now, since 2010. Initially, our foundation is focusing on provider education, because if diagnosis and optimal treatment are key challenges and key gaps in caring for women and girls with bleeding and other blood disorders, we better get on with the medical education and training and the nursing education and training. Since we started launching our education programs in late 2011, we have now reached over 5,000 providers in our first 5 years. We looked at end of 2011 to end of 2016, and these are the data. We educated over 5,000 hematologists and OBGYNs predominantly, and we did at 32 society symposia, workshops, medical meetings, and through 8 webinars. We're way up beyond that now, but these data are taken, as I said, for our first 5 years, 2011 through 2016. In addition to going to the American Society of Hematology, the North American Society for Pediatric and Adolescent Gynecology, and other important national society meetings, FWGBD has begun to create its own meetings around important topics to educate and train providers and change health outcomes for women with bleeding disorders. The most recent one was just held this year in Arizona, and it was a 2-day meeting specifically on uterine hemostasis and taking care of the challenges for abnormal uterine bleeding during the reproductive years and some of the later life stages. What's important about our own convened meetings particularly, we will have an article that shows and shares the outcomes of this particular meeting across the nation and in fact internationally, where providers, hematologists, and OBGYNs who comprise the faculty and their colleagues across the world will learn how to handle these challenges. From all of our work in educating providers, we received a phone call in late August, early September 2013, from the Oregon Health and Science University. Michael Recht and his new hire, Dr. Christina Haley, were seeing a lot of women in their HTC, their Hemostasis Hemophilia Thrombosis Clinic, or Center, HTC as we call them in the abbreviation. They saw so many women and young girls and young women that they decided they were going to have a designated clinic. And they were told, call FWGBD because they can help you make it a clinic of excellence for young women and girls. That was the impetus for us beginning this mechanism for connecting the centers that wanted to be clinic of excellence with the established centers that had been serving women and girls for a long time, and many of which had a designated clinic. So we had the mechanism that our education director, Carrie Funkhauser, whom you're going to hear from soon, and our board member, Leslie Graham, knew about this methodology for connecting different entities so they could collaborate on learning. The Learning Action Network, and ours is the Women Girls Blood Disorder Learning Action Network, it brings together healthcare professionals around a specific project or topic or agenda focused on getting outcomes. It harnesses collaboration and it does all of the things you see here. They are very, very focused. The newer centers like Oregon Health and Sciences, SPOTS, DOTS, and CLOTS Clinic for young women and girls, and the established centers like the one at Baylor College of Medicine and the one at Nationwide Children's that you're going to hear from and hear about very soon. We harness the established with the newer centers and the exchange of learning, taking common practice and making it best practice. That's what we're focused on, and creating clinics of excellence across the nation that will get us to our vision: early diagnosis and optimal treatment for women and girls with bleeding and other blood disorders. Here's what has happened just since the fall of 2013, where 7 members were in our Learning Action Network, and you can see Oregon Health and Science among them because they were kind of the catalytic. I guess I don't see them here, but they were one of our early, they were the first by giving us the idea to have it. Oh, here it is. I'm sorry. It's just the initials, Oregon Health and Science University, which became SPOTS, DOTS, and CLOTS Clinic. Now we have 63 members across HTCs, and the 63 members are working out of 43 of the 140 HTCs. That's 31% now in our network, trying to improve and optimize the kind of care they deliver for women and girls. I wanted to share with you the amazing outcomes in just the short period of 2013 to early 2017. 13, if you count these up, 13 new designated clinics for young women and or adult women with bleeding and other blood disorders have been established since we've been working through this mechanism of Learning Action Network, late 2013 to early 2017. We think that's value added for all of you in the audience who are women or young women with bleeding or other blood disorder, and for the many more we are serving across the country. I'm going to now invite our Dr. Carrie Funkhauser, our Director of Education, to continue with our discussion.
Thank you, Anne-Marie. That was great. And thank you, everyone, for joining us today. My job now is to provide you with a little bit more detail about two items that we're currently working on, both pertaining to designated clinics for women and girls. And as Anne-Marie mentioned, we know that our land members are all incredibly enthusiastic about providing and improving services for women and girls. But a question remained among all of us was what was happening at the other HTCs across the country that we weren't working with through our land and through other avenues. But before I go any further and describe how we attempted to answer that question, I'd like to ask you two questions. And the first question is, I want to know if you've ever heard about a woman or girls only specialty clinic for bleeding disorders. And if you could just give us your answer quickly. Great. Okay, so about half have and half have not. Great, thank you. The next question is, how many of you know if your local HTC or the HTC within your state has a specialty clinic for women and girls with bleeding disorders? Okay, so about 78% are not sure if there is one, and 22% do know of one. So wonderful, thank you. So we were in a similar fashion. We were not sure about how many HTCs had a specific clinic. And so we turned to the CDC and we asked them and said, do you have a list of the HTCs that have a specific designated clinic for women and girls? And they said, gosh, we don't have a list like that. And we don't have anything written down. And we said, well, we'll take care of that. So in November of 2015, we set out to interview every HTC within the federally funded HTC network, which is now 140 centers, to find out what types of services they offer women and girls and whether or not they have a designated clinic. One of the first things that we saw and found was that 25 of the 140 do have a designated clinic. And you can see on this slide what I mean by a designated clinic is that it is a specific clinic, specific bleeding and or blood disorder clinic that is open at specific times and or days and sees only female patients at that time. So out of the 25, 7 of them offer care for both women and young girls, 16 offer care for adolescents, and 2 offer care for adults only. And there were some other interesting things that we found as we did these interviews. We found that 11 plan to designate a clinic within the next 18 months of our survey. And we have found that several of them have actually followed through and created that clinic, as Anne-Marie alluded to before. 40 of them actually offer services or outreach clinics, maybe not a designated women's only clinic, but they offer services outside of their main facilities location, which is so important because many HTCs are located in areas that many women cannot get to. So to be able to access services close to home is so important and so important to the care of women and girls. One of the other things that we found very interesting and resonates with a lot of the research that has been done is that 92% of the HTCs that answered our survey said that the most common condition that they see is HMB, or heavy menstrual bleeding or heavy uterine bleeding. Some of the other conditions that they commonly treat among women and girls at the HTCs are prolonged menstrual bleeding, deep vein thrombosis, dysmenorrhea. They also monitor and care for women during their pregnancy, and they also treat ovarian cysts. Another question that we asked was what types of providers and specialists are most commonly included in the visits for women? And you'll see here to the right a picture of the incredible team from MSU, Michigan State University, Roshni Kulkarni team and their clinic team. They have a wide variety of specialists that are involved in the visits with women, and so do the other HTCs. And as you can see here, nurses and social workers, pediatricians, physical therapists, nurse practitioners, genetic counselors, down the list. We have quite an array of specialists that are involved in these visits, which is really reassuring. Another question that we asked in the project was we wanted to know what type of OB/GYN care was provided for women when they came to the HTC and/or the designated clinic. 71% or 75 of those that answered said that they offer access to specialized care outside of the clinic. They may not be able to offer it within the walls of their clinic, but they have it there on their campus. 14% said that they are able to offer it and outside the walls of their clinic or HTC, which is really exciting. 9% or 9 offer it within the clinic, and then 9% or 10 said they don't offer specialized care within or access to the care outside, but many of them wrote comments saying they are working on those relationships. They do have a place to refer women, and so they are working to get something more in place, which is very reassuring. So what we did with all of this information is we created a directory, and you can find this directory on our website at fwgbd.org/clinics. On the main page of the website, if you were to scroll down, you will see a bottom of the page, and you'll see a search button. And if you're looking to see about more information about the HTC within your state or location, you click on that search button, and it will bring you to this screen here, where you're able to refine your search either by a clinic name, by a city, and/or state. And for an example, I've placed Texas as the state where I'd like to search, although I live in Idaho. We're going to look in Texas. And when I do that, what comes up are all of the centers that have answered our survey. Some of them, again, only 121 have answered currently. So there are a few that haven't answered, but we will get them all. But for right now, there are 4 within Texas that offer services. And I've decided to look at one in particular, the Children's Medical Center in Fort Worth, and actually at Texas Children's Hemostasis Thrombosis Center, at Baylor. And this is the information that they have provided to us. They do offer a clinic for adolescent females, and they offer it twice per month on Tuesday and Thursday. They've given us the hours that they offer that clinic. They also tell us what eligibility requirements are in place to be seen at that clinic. So women and girls with heavy menses who need evaluation, those who have identified bleeding disorders already, and then women and girls with other blood disorders as well. They also list the services they provide during their visits or access to those services outside of the combined clinic visit. And then they also talk about the type of OB/GYN care provided. We also will provide a phone number and a website if that is available to us, and we will share that with you. So all of this information is available for you in this directory on our website. One thing I need to make clear is that we don't state if a center is excellent or if a center is poor. We do not rate the centers. We are just providing the factual information that is given to us from the HTC. But we do want to know a little bit more about clinics in general and what makes a clinic of excellence. If you know anything about the Foundation for Women and Girls with Blood Disorders, our founding mothers, as Anne-Marie affectionately calls them, and Anne-Marie herself, we don't stop with just finding out what the facts are. We also want to know why, and we also know what we need to do to make something a clinic of excellence. And so that is something that we are working on right now, is trying to identify what makes a clinic of excellence. And our definition of a clinic of excellence right now that we are working with is that it is a center that has a combined approach of offering guidance to others who are interested in approaching care from a common background, where the most common denominator is heavy menstrual bleeding. And what I'd like to ask you right now, if you wouldn't mind just typing it in the chat box, I want to know from you, the audience, what you think the biggest element or elements are that would make a designated clinic for women and or girls a clinic of excellence. So if you feel like chatting, putting those in the chat box, that would be great. We've worked with our land members as well as our board members and our extensive list of professionals that we work with on webinars and other programs, and asked them to help us identify what the core elements are of a clinic of excellence for women and girls with bleeding disorders. And in working and in talking with them, they have been able to help us hone a model of what this clinic should include. And what I'm showing you right now is a really, really important, albeit simple slide. And that's because this is our formula. So in a sense, if you could create the perfect ideal clinic where you would get all of your healthcare needs addressed as a woman or a girl with a bleeding disorder, and what you would want or need, that is what this slide is including and saying. It shows the combination of services and attributes that our experts feel are needed in order to provide or to ensure that women and girls with bleeding disorders get the proper care that they need. And to get to that center circle, that clinic of excellence, one must incorporate all of the 5 surrounding elements in order to achieve success. And what's really important about this diagram is that there are hundreds of things that lead to that center circle. And each little circle, each of these specific elements, are those that were identified as making the most difference on that ultimate outcome. So it is these things that give the greatest amount of variance within a clinic and are the things that contribute most to hitting that circle. And amongst these 5 elements, some of them are indeed more powerful than others. And because of time, I'm just going to highlight a couple of those for you. And the first one I want to highlight is this top center circle, the top of the model. And that refers to the marriage of the OB-GYN and the hematologist, or the adolescent medicine provider and the hematologist. I am sure I don't have to tell you about the frustration one experiences when we go to see a provider about one condition and have to wait for a long time to then only be immediately referred to another specialist because the first one cannot answer our questions or help us with this issue or address it alone. So by offering this cross-discipline, multi-specialty care in one setting provides an amazing and a very much needed opportunity for women to get the medical care, that holistic care that they need. It's fundamental to the success of a care for women and girls with a bleeding disorder, and hence is one of our core elements for a clinic. The second core element is the collaborative care team. That's because we need these other critical members of the HTC team. And luckily for the hemophilia community set that incredible example for this type of collaboration years ago when they went to Congress and said, you cannot take care of us properly if you don't give us the cross-discipline multi-specialty care in one setting. And that's what happened back in the 70s, and that model that was created became a model of excellence for others to follow. And women with bleeding disorders, women are very, very lucky that they can be part of this treatment center network and have that collaborative care. The other elements are very crucial as well. Assessment, obviously ongoing assessment is important. It's important for patients to be able to express if they're satisfied in the care that they are getting, they're getting timely care. Also clinical outcomes regarding patients, are their lives improving? Are they getting better because of what we give them in the clinic or from our services? And as providers, screening, are we screening appropriately and in a timely fashion? Are we getting patients to the right clinics and to the right specialists? All of those things are important to assess and look at those outcomes. And ongoing education and continuing education is crucial so that we continue to educate not only providers within the institutions where we work, but also community providers. So they're aware that the clinics are there, that these services are there, that they know where to refer these women and girls. And so that's a very important piece of the puzzle, as well as continuing to do research to improve the outcomes, to enhance and create a center of excellence for women and girls. Moving that model into what women need and adding that element of reproductive health professionals, we are now seeing in the literature that comprehensive multidisciplinary clinics for women and girls are being recognized. For example, this just quickly, in hemophilia, one of our land members, Dr. Aisha Zia, who moved from Detroit to Texas, the University of Texas Southwestern, wrote about her experience of setting up a clinic. And when she got to UT Southwestern, she immediately went to her division chief and said, you know, we serve young women and women with bleeding disorders, and I want to start a clinic just for them. And the division chief said, well, you show me how it's done, you make it work, and I'll let you keep it. So she did it. And this article describes what she did to do that. And in the same journal article, Dr. Barbara Conkle, one of our founding mothers, was asked to review Dr. Zia's article and wrote a commentary about it. And what she wrote was this paragraph here, that women and adolescent females with bleeding disorders have unique healthcare needs, which are not uniformly met by their healthcare system, including specialized bleeding disorder programs. And attention to these needs of these women and girls and the development of designated clinics directed to their care, as described by Zia and colleagues and supported by the Foundation for Women and Girls with Blood Disorders, is an effective and promising way to meet the needs and improve the outcomes for female patients with bleeding disorders. And I don't like to read that, but it is a very important statement. And so we encourage you to take a look at that commentary and article. So the last thing, and what I want to close on before I turn the slides over to Dr. O'Brien, is that I want to point out that these clinics may vary from site to site. They may vary to how they look, and they may vary to how the services are provided and which services are provided. One thing is very certain, and that is that clinics of excellence will have the core items identified from our model. So with that in mind, I'd like to introduce you now to two extremely talented and wonderful professionals at Nationwide Children's Hospital in Columbus, Ohio. Both are the co-directors of the Young Women's Hematology Clinic. Dr. Sarah O'Brien is an associate professor of pediatrics in the Division of Hematology Oncology at The Ohio State University. And Dr. Farida Hamid, who is an assistant professor of pediatrics in the Division of Adolescent Medicine at The Ohio State University, will speak after her. They're going to spend a little time now introducing you to their clinic and how their multidisciplinary approach makes it much more straightforward and allows for a better patient experience and better patient outcomes. Dr. O'Brien.
Thank you. It's a pleasure to be here today. I'm going to talk a little bit about, again, building the case for why these clinics are so important from the physician perspective. And then Dr. Hamid is going to talk more about the nuts and bolts of how we run our particular center. So next slide, just some more information about creating the case for a multidisciplinary clinic. And next slide. Quite simply, one important reason is that our population continues to grow. We continue to have more women in the United States, more young women in the United States, so more patients to be seen. And the primary goal of the Foundation for Women and Girls with Blood Disorders, or one of the primary goals, is to increase awareness of women and bleeding disorders and the importance of considering bleeding disorders when evaluating heavy menses. So if we do a good job and fulfill our goal, hopefully we have a lot more patients seeking our care, and we need to have places for these patients to be evaluated and treated. As Anne-Marie mentioned, bleeding disorders are common, particularly mild bleeding disorders. And out of all of the women who present with heavy menses, up to 20% of those women can have an underlying bleeding disorder, which is a pretty high number. And the point I want to highlight on this slide is the variety of physicians who see women presenting for the first time with heavy menses. We are in the process of writing up a study at our center looking at just this across the United States. And it's pretty amazing how equally it's divided up. Young women are as equally likely to show up in their pediatrician's office for the first time, in internal medicine doctor's office, family practice, gynecology, or in the emergency room, which is where we hope they're not coming for the first time. But it was almost equally divided between all of those practitioners. We have a lot of physicians that we need to educate about women and bleeding disorders. Dr. Hamid and I just had clinic this morning, so I can certainly say that we spend a lot of time during our visits really getting into the details of patients' heavy menstrual bleeding and determining how heavy the bleeding is, and has their bleeding improved since the last time we saw them, since we started their therapy, since we tweaked their therapy. The formal definition of heavy menstrual bleeding is greater than 80 mLs of blood loss, which is about 5 tablespoons. That's obviously very hard to track outside of a research study. So we talk about indicators or red flags of heavy menses, and this would include periods that are lasting more than 7 days, women who are needing to change their product after just an hour or two, women who are needing to wear double protection, wearing a tampon and a pad or 2 pads at the same time, having to get up at night to change your protection. And it's important to ask all of these detailed questions and not just ask if your periods are heavy, because women often don't talk to each other about menses, or they might just be comparing their menses to their sister or mother who also may have a bleeding disorder. So abnormal versus normal, not every patient knows that. So you really have to get into the details. And we also find out if the patient has been diagnosed with iron deficiency in the past, and if it hasn't been checked, we certainly check that the first time we meet them. A lot of times when you read research studies about heavy menses, you'll see something called the PBAC, which is a way for patients to more accurately track their menstrual periods. So Dr. Hamid and I see teenagers. So very few teenagers are able to sit down in the office and fill this out for us from memory. And most of our patients are on their phones all the time. So we've moved from this more to publicly available apps that are available on phones so that girls can track their menses and be able to give us more detailed information at the next visit. As Dr. Nazzaro mentioned, heavy menstrual bleeding is a very common problem. In one survey of teenagers, over a third reported heavy menstrual bleeding. And I think that one of the barriers that we face as pediatricians is a lot of times if there's heavy bleeding during the first year or two, that's often dismissed as, oh, it's an ovulatory bleeding, their hormones are still learning to talk to each other. But what physicians and patients need to understand is that women with bleeding disorders also have anovulatory bleeding. Typically, women with bleeding disorders, their periods are at their heaviest when they start, and then at the end when they're going through menopause. So it's important not to dismiss young patients with unusual bleeding just because they have recently started their menses. We also have several studies that have shown that heavy menses affects quality of life in teenagers. And certainly this is something that Dr. Hamid and I see in our clinic, that girls are missing school because of their heavy menses. They are not participating in gym class. It's difficult for them to participate in sports. They may avoid some social activities, and they have a lot of anxiety about having leaks at school, having to leave school early, etc. And one of the important questions is, what are the barriers to seeing a hematologist? Why don't we see more of these patients? Why does it take so long to diagnose women with bleeding disorders? So one fact I just mentioned is that patients and their parents may not recognize that their menses are abnormal. Gynecologists see lots of women with heavy menses, and there can be many causes for heavy menses. And the most common therapy we use, which is hormonal contraception, can treat heavy menses almost regardless of the underlying cause. So we need to make sure that we're not just treating the heavy menses, but understanding the reason behind them, because that impacts the care a patient may need to receive during pregnancy or surgeries, et cetera, if there's a bleeding disorder as the underlying reason. And finally, we have a recognized shortage of hematologists for these patients to see. So even if a general practitioner recognizes a problem, they may not have access to a hematologist. And this is particularly a problem in adult medicine, where benign hematology specialists are even more scarce. So with that, I will let Dr. Hamid take over and discuss what we do at Nationwide Children's.
Good afternoon, everybody. I am happy to be a part of this webinar. Thank you so much for inviting us to share our clinic experience. So I wanted to talk about the basics at Nationwide Children's Hospital Young Women's Hematology Clinic, sort of the who, what, where, when, and whys of how we get this done. Essentially, the people referred or sent to us from other providers are adolescent females. The classic referral is for heavy menstrual bleeding, and they are referred to our multidisciplinary dual physician clinic, which occurs in a suburb of Ohio near Columbus. When we meet, well, Dr. O'Brien alluded to the fact that we were in clinic early this morning. So 1 to 2 Thursdays a month with a max of about 10 patients per session. And that is the limit of what we can comfortably do to actually get everybody's needs met and not have disgruntled people in our waiting rooms. So the why of how this got started is we really wanted to reduce the wait times. So the goal was to make this a less taxing, cumbersome experience for patients and families, and really talk about what Anne-Marie talked about earlier, which was shortening the interval between when the symptoms start and when we actually have a diagnosis made. The other thing we noticed in our past experience was that about a third of patients were initially referred to hematology, who were also referred to adolescent later, and then vice versa. So the thought was that maybe we could, if we got us all in the same location, we could have a more one-stop shopping type of clinical experience, which we think our patients appreciate. Next slide. So the clinic team, who all comes to clinic? We have 2 physicians, Dr. O'Brien and myself, and we have some trainee physicians who also come at certain times during the year. We also have a well-seasoned hematology nurse practitioner who sees our follow-up patients. So oftentimes we see an initial patient, and then they will see the nurse practitioner, and we'll come up with plans. We still discuss everybody's care together. The nurse clinician is vital to this clinic. They are looking at referrals, they are triaging calls and assessing who needs to be seen immediately, who can be seen at a later time. The education component is also done by the nurse clinician, lots of education about iron-rich foods, which are important. Phone follow-up, so once we get results, relaying those results to families and letting them know about next steps, and also being that voice that parents or patients can talk to. We do have a social worker present in our clinic who also just does an assessment of what the psychosocial needs may be, if there is paperwork to be completed that can help a family with insurance or the cost of the visit, we get that taken care of as well. And then an RN who comes to basically with her skates on, rooming patients, doing vital signs, blood pressures, heart rates, keeping patient flow, knowing who needs to go to lab and who needs still to be seen by a physician, and administering handouts and thus reminder phone calls for the next session. when we can offer it, we do have a nutrition person available, often a trainee from the Ohio State University, who really helps seal the information in about iron-rich foods and things like that. Not on the slide here, we also have research recruiters, because it's also important to advance our knowledge base in this field and create patient registries, and where parents and patients will agree to participate in studies, we do recruit them. We also have on-site phlebotomy, and they are trained very well to watch for dizziness and passing out before or after, or during the actual lab draw. Next slide. So the clinic format, the way it typically runs, we have all patients that are seen by Dr. O'Brien and myself. So that's hematology and then adolescent medicine. And if you are not familiar with both services, I'm sure you are familiar with what hematologists do. For adolescent medicine, this is typical office gynecology. At other institutions, it may be gynecologists, but at our institution, the adolescent medicine component is done by myself. So we will have a patient come in, and they will be roomed by the nurse clinician, and we will take turns seeing the patient. We meet in a room and discuss the patient's care before the next person goes in, and really try to hone in on what the patient will need next. And the follow-up visits are seen, as I said before, by our nurse practitioner, and if need be, by myself, to sort of tweak what is necessary for care or figure out the next testing to be done. Oftentimes, patients are doing just fine on the new medications or the new approaches we've tried, or they need a little bit more. So our new patients are seen for initial consultation, and then once we have lab results come back or get more records, we can sort of tailor make their care, and which is really appreciated by the family, so that they know there's one place they can get it all done. So if we do establish a bleeding disorder diagnosis, we talk about what further testing is needed, the meds that are specific to that patient. Oftentimes, as Dr. O'Brien stated, there's a anovulatory or lack of ovulation if the girl is newly starting her period. So we decide, is it worth hormonal medication to regulate? Do we need a medicine that has a more hematologic approach? And then we follow up the progress or side effects of any kind, of any therapies we started, and address new concerns. So referrals at NCH are from hematology for heavy menstrual bleeding. Heavy menstrual bleeding was formerly known as menorrhagia. In 2012, there was a consensus of gynecologists who met in a European city. I always say it was Geneva because it seems very intriguing, but I'm not sure where they actually met. But they decided that the term heavy menstrual bleeding was a little bit more descriptive. So we get referrals for heavy menstrual bleeding. We have a nurse clinician who calls the family to assess. So how acute is the issue? Are the periods really bad and they need to be seen soon, or can we do it at a later time? What preferred site they'd like to be seen at? Is it our downtown location or one of our satellite clinic? If they already have a well-established rapport with the gynecologist, perhaps they can just see hematology instead of seeing both of the providers at our clinic. So as we've grown, we now also literally get referrals that just say referral for menorrhagia clinic. And that means that we're doing our job and the word is out there that we are the ones that people want to see for heavy bleeding. We also do get referrals for contraception consultations because there are women who have a personal or family history of clotting, and so we have to be very careful about how we treat them and what medications they can have. What we also see is that because the word is out about what we do, we are at a teaching hospital, so our resident and fellow physicians are becoming very astute at who who needs to come to this clinic. Just earlier this week, I got an email from a fellow in training who said that she knew if a patient who was coughing blood for a year and had a battery of tests came to see her, and she knew right away from rotating in our clinic that the patient needed testing for von Willebrand's, and we made the new diagnosis of von Willebrand's. So the importance of training people to recognize what's needed is very important, and Anne-Marie did a great job of explaining how we're hoping to change that. So what I want to share now is just some experiences from our clinic in the first 18 months, starting in 2008. What we had about 60 new patient referrals. The age breakdown was about 15% of 10 to 12-year-olds, and as you can see, 13 to 15-year-olds, 44%, and 16 to 19-year-olds, 41%. They came from Franklin County, which is where the clinic is actually located, 41%. Surrounding counties, 22%, but most importantly, far away places, 37%. So it underscores the need that we need to have new clinics so that these people don't have to drive so far away. Referring clinicians were a variety of specialties such as family medicine, internal medicine, pediatrics, and OB-GYN. Next slide. So now updating our clinic experience to date from January 2015 to last month, July 2017. You can see here as the years have progressed, we have seen more unique patients, and I will underscore that a unique patient is a new patient who has never been seen before. So this is very important that we're getting new referrals. We have already seen about 2/3 of the patients we saw last year already by July. So we expect to see a lot more patients this year, and we think that's a good thing. So what are patients saying? So we think we're great, but what do our patients think? They are giving us very positive feedback. They love having access to both providers in one site. They like that their questions can be addressed. There's also less confusion because as parents, sometimes I leave the room and they forgot one last question to ask the hematologist, and I can ask really quick. And you can imagine if we weren't in the same room, then maybe there's 2 or 3 phone calls before one simple question is answered. It also gave them an ability to cope and move forward. So what we know is that coping is quite important. And while these are sometimes very weighty diagnoses, people appreciate and have some relief of knowing the actual diagnosis, that it can be treated versus this curse of just having bad periods, which often leaves little hope. So the other thing is they like knowing that if they had questions, they could call either adolescent medicine or hematology for direction. And what's important here is also with the advent of the electronic medical record, it's all there for providers to see. My notes can be seen by the hematology staff, and Dr. O'Brien's notes can be seen by the adolescent medicine staff. So it's really helped us save time, get patients to where they need to be. We are going to just highlight a YouTube video of our clinic, and we can roll that if possible, Carrie. Thank you.
I'm here for a follow-up appointment.
Right here.
Last year in August, I had a bleeding problem. I couldn't stop bleeding. They realized that my blood count was down at a 6 when it should be up at a 12. I was diagnosed with menorrhagia, which is where you have irregular cycles and very heavy bleeding.
And then step right up here.
There are a few aspects of heavy menstrual bleeding that define that. So one is any period that's lasting more than 7 days, and also looking at their iron levels. Patients who have low iron, that's a big sign that their periods are heavy.
I just thought girls would have like heavy periods sometimes, but I never knew there's a diagnosis with it. I never understood that there would be a place where you can go and talk to somebody about it.
How much product did you use in those?
Today we came up with a plan to give her regular periods, but have them be more predictable. It's one place where people can see experts in the field. You do need people passionate about both the hematology aspect and the gynecology aspect of it.
You're having kind of shorter cycles. If you can manage the bleeding disorder, you can avoid major surgeries like hysterectomies.
Being a parent of a young girl and having gone through adolescence myself, you really want a team with you that's going to look at the whole picture.
They are willing to do anything to get you back to a good, active, healthy life.
Hey, how are you guys?
She's blossoming as a young woman, and it's nice to kind of put the periods on the back burner and not have it run her life.
I think patients understanding that this clinic exists is helpful because automatically they know that there are other girls like them. One great thing is that more and more of these clinics are opening across the country, which is so important because so many women are still under-recognized as having a bleeding disorder.
We're really proud of the work we do here, and I think it should become even more commonplace as we get the word out.
Every girl goes through bleeding. If you have heavy bleeding, it's okay. Just talk to your mom, talk to your doctors.
The Young Women's Clinic at Nationwide Children's Hospital has changed our lives. I mean, for what we had gone through over the last year, I don't know what I would have done without them.
So we wanted to say thank you from the Foundation for Women and Girls with Blood Disorders, Dr. O'Brien and myself. Thank you all for your attendance at this webinar, and we appreciate the opportunity to spread the word.
And it is top of the hour, so I guess we'll go ahead and wrap up. And again, I just want to thank you to all of our presenters for your time today and for your insightful presentation. And thank you to all of our attendees too for joining in this afternoon. Just a reminder again, this webinar is being recorded and we will make it available shortly on HFA's website via our resource library and also on our YouTube channel. If you do have any questions, please feel free to contact webinar@hemophiliafed.org, or you can simply reply to the webinar confirmation email you received. Thank you all again for your time, and hope you have a wonderful